Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast.
Today, we're looking at a review article from the Korean Journal of Radiology, published in 2025. The title is State-of-the-Art Imaging in Antibody-Drug Conjugate Treatment for Advanced Bladder Cancer.
A significant topic. Advanced bladder cancer presents major challenges, and this paper dives into a class of drugs that are really shifting the therapeutic landscape.
Exactly. We're talking about antibody-drug conjugates, or ADCs. This review synthesizes the critical and evolving role of imaging in this new era of treatment.
Okay, so let's start there. What exactly is an ADC?
At a high level, they're often called smart chemotherapy. It's an elegant concept, really. They consist of three parts: a monoclonal antibody, a cytotoxic payload, and a linker holding them together.
So it's targeted. The antibody is the guidance system.
Precisely. The antibody is engineered to find a specific antigen that's overexpressed on tumor cells. Once it binds, the whole complex gets internalized by the cancer cell.
And then it delivers the payload.
Right. Inside the cell's lysosome, the acidic environment typically cleaves the linker, releasing the cytotoxic agent right where it can do the most damage to the tumor cell, which is meant to minimize systemic exposure.
That's the theory. What are the key ADCs and their targets in bladder cancer?
The paper focuses on a few key players. First is enfortumab vedotin, or EV, which targets an antigen called Nectin-4. Then there's trastuzumab deruxtecan, targeting HER2.
And I see a third one mentioned, sacituzumab govitecan.
Yes, that one targets TROP2. Though it's an important data point that the paper notes it was voluntarily withdrawn for advanced urothelial carcinoma after a phase 3 trial didn't meet its primary endpoint for overall survival.
A crucial detail. So focusing on the ones in active use, how have they been integrated into the standard of care?
They've been rapidly integrated. The paper points to the NCCN guidelines, where enfortumab vedotin, for instance, is now a primary treatment option across multiple lines of therapy.
Even first line?
Yes, in combination with the immune checkpoint inhibitor pembrolizumab for both platinum-eligible and ineligible patients. It's a fundamental shift in the treatment algorithm.
Which means the role of imaging must be shifting just as fundamentally.
You nailed it. The review emphasizes that imaging is now pivotal for assessing treatment response, detecting recurrence, and, very importantly, evaluating toxicity from these new agents.
Let's drill down on response assessment. The paper says most clinical trials for these ADCs used RECIST 1.1. How well does that work here?
It's still the standard. One interesting point the authors make is about pseudoprogression, a known challenge with immunotherapy where a lesion can appear to grow due to immune cell infiltration before it shrinks.
Right. That led to the development of criteria like irisis.
It did. However, the paper states that pseudoprogression has been reported to be very rare in urothelial carcinoma. So the bottom line is that RECIST 1.1 is considered a reliable criterion for bladder cancer treated with ADCs.
Okay, so if RECIST 1.1 is generally sufficient, what's the big challenge in assessing response?
The primary bladder tumor itself. The bladder is a dynamic, hollow organ. Its appearance changes depending on how full it is, which can complicate measurements.
And post-treatment changes must be a factor.
A huge factor. After therapy, scar tissue from a treated tumor can present as mild bladder wall thickening on CT or MRI. A radiologist might see that and call it a partial response, or a PR.
But pathologically, it might be a complete response, a CR.
Exactly. This is a non-trivial discrepancy. The review cites a study on enfortumab vedotin that's pretty striking. It reported a CR rate of 0% for primary bladder tumors based on imaging.
0%? That's a red flag. What were the CR rates for metastases in that study?
Much higher. For lymph node metastases, it was 5.5%, lung metastases, 29.4%, and for liver metastases, it was 18.2%. In those solid organs, tumor measurement is just more straightforward.
So, how does imaging get better at evaluating the primary tumor site? What's the path forward?
The paper points toward multiparametric MRI. It gives you more than just anatomical information. You get functional data from diffusion-weighted imaging and perfusion characteristics from dynamic contrast-enhanced sequences.
What's the specific finding that might signal a true CR?
The paper suggests that a key feature could be dense T2 hypointensity, so it's dark on T2-weighted images, but without diffusion restriction. That combination might be the signature of fibrotic scar tissue rather than viable tumor.
Got it. So it's about looking for a specific multiparametric signature, not just a change in size. Are there other tricky areas for response assessment?
Yes, bone metastases. They're common in advanced bladder cancer and present their own set of problems.
Such as?
Discordant responses. This is where metastases in different parts of the body respond differently to the same systemic therapy. The paper includes a compelling example in its figure 4. It's a CT from a patient on enfortumab vedotin. The baseline scan shows bilateral hilar lymph node metastases and an osteolytic lesion in a rib.
Okay.
The follow-up scan 4 months later, the hilar nodes have shrunk nicely. That's a good response. But the osteolytic rib lesion has actually gotten bigger. It's progressing.
That's a tough situation. How do you score that overall? A mixed response?
It makes the overall assessment very complex, and it underscores why standard abdominal and pelvic CT might not be enough. The NCCN guidelines actually recommend dedicated bone-specific imaging in these cases.
Like a bone scan, a dedicated musculoskeletal MRI, or an FDG PET?
Exactly. To get the full picture.
Okay. Let's pivot from response to the other major role for imaging, toxicity. These drugs are targeted, but they aren't without side effects.
That's right. The paper does a nice job breaking down the two main mechanisms of toxicity.
Go on.
The first is off-target toxicity. This happens when the cytotoxic payload gets released from the linker prematurely, while the ADC is still in the bloodstream. It's no longer targeted.
And that can cause systemic chemotherapy-like side effects. The paper mentions neutropenia, anemia, and pneumonitis.
Correct. The second mechanism is on-target off-site toxicity. This is more subtle.
Define that.
This occurs when the ADC correctly binds to its target antigen, but on normal healthy cells that happen to express it at low levels, not just on the cancer cells.
So for EV, the target is Nectin-4. If normal skin cells also express some Nectin-4, you could get skin toxicity.
You nailed it. That's why dermatological toxicities like rash and pruritus are common with EV. Same with ocular toxicities like dry eyes because Nectin-4 is also expressed in ocular tissues.
So each ADC would have a unique toxicity profile based on its target and its payload.
Exactly. The paper's Table 3 is a great reference for this. For EV, the profile is dominated by those on-target skin and ocular issues, plus off-target peripheral neuropathy from the MMAE payload. For sacituzumab govitecan, its issues are more gastrointestinal and hematologic, because its payload is SN38, the active metabolite of the chemotherapy irinotecan.
And what about trastuzumab deruxtecan?
That one carries a well-known and significant risk of interstitial lung disease and pneumonitis. A meta-analysis mentioned in the review found it occurred in 12.5% of patients, with 2.2% being severe, grade 3 to 5 events.
That's a serious risk. So let's talk about what these toxicities look like on imaging. For pneumonitis, what are the typical findings?
The paper's Figure 5 has several clear examples on chest CT. You often see multifocal nodular ground glass opacities, sometimes with areas of consolidation.
Is there a dominant pattern?
For enfortumab vedotin-related pneumonitis, one study found that the most common pattern, seen in 2/3 of cases, was organizing pneumonia.
How quickly does it appear?
The median time from starting EV to the onset of pneumonitis was reported as about 13 weeks. It's often treatable with steroids and is usually reversible, but it needs to be caught early.
Okay, and for gastrointestinal toxicity?
The common findings on CT are what one might expect with enteritis or colitis. Figure 6 shows a case with fluid-filled and dilated colon loops, along with some mild wall thickening.
So radiologists need to be aware that these findings in a patient on ADC therapy could be drug-related toxicity.
Absolutely. It needs to be on the differential, especially when a patient presents with symptoms like severe diarrhea. In rare cases, you can even see superimposed neutropenic enterocolitis, which would show more dramatic edematous bowel wall thickening and fat stranding.
So pulling this all together, let's frame this as a playbook for a radiologist. What are the key takeaways from this review?
The paper provides a really useful summary in Table 4, which addresses common radiology-related questions. First is knowing the right modality for the job.
For baseline and screening, the NCCN guidelines recommend both CT and MRI for evaluating the primary tumor and metastatic disease. A chest, abdomen, pelvis CT is still a workhorse.
Right, and for suspected bone or brain metastases, the guidelines recommend dedicated imaging, FDG PET CT or a bone scan for the bone, and a brain MRI for the brain.
Second takeaway, when assessing response, be cautious with the primary bladder tumor.
Yes, remember that what looks like residual disease could be scar tissue. This is where multiparametric MRI might be particularly helpful to differentiate a PR from a true CR, especially by looking for that T2 hypointense but non-restricting signature.
And third, be vigilant for signs of toxicity.
Precisely. That new ground glass opacity in the lungs of a patient on EV or trastuzumab deruxtecan isn't just a potential infection. Drug-induced pneumonitis must be considered. Clinical correlation is key to differentiate from infectious pneumonia.
Knowing which ADC the patient is on helps narrow the search.
It's critical context. The antibody and payload dictate the likely toxicity profile, which guides what to look for and where.
The paper also briefly touches on the future, with new ADCs in development and clinical trials exploring their use earlier in the disease course, like in the neoadjuvant setting.
Yes, the field is not standing still. For instance, they mention a trial combining disitamab vedotin, another HER2-targeting ADC, with a PD-1 inhibitor as a neoadjuvant regimen, showing promising early results.
So the complexity is only going to increase.
It is. I think the core message of this review is that radiologists must be knowledgeable members of the multidisciplinary cancer care team. The mechanism of action of these drugs directly impacts the imaging findings.
So the bottom line is that effective interpretation in the age of ADCs requires more than just anatomical expertise. It requires an understanding of the underlying biology of the therapy, the expected patterns of response, including the tricky ones, and the specific signature toxicities these powerful agents can cause.
A well-put summary. It's about connecting the molecular mechanism to the radiological manifestation. A new paradigm for imaging in bladder cancer.
That's our look at state-of-the-art imaging for ADC-treated advanced bladder cancer.
Thanks for tuning in to SummaryCast.